Papyrus, but in fact, sorry. But in fact, Dr. Vasilev, come back. Because the audience liked you very much, appreciated your presentation, and you are going to have the honor to present our experience with Papyrus stent-graft for complex peripheral pathology.
Yes, and also for there is a case about the coronary pathology also in this presentation. So, okay, the Papyrus, basically a covered stent, which is an ultra-thin stats. It is balloon expandable, and it is covered on the abdominal surface, and it's with a matrix that is MRI conditional. The Papyrus stent, it's not the only one covered stent, but there is a great flexibility, smaller crossing profile, and it is the only one that can be used with a 5 French guiding catheter. So basically perfect for tortuous anatomy in the peripheral and in the coronary anatomy. We have 16 patients with different peripheral pathology. The most important thing is the peripheral, because the Papyrus is only approved to be used in patients with coronary pathology. So every one of these patients is off-label, but basically, despite that the guidelines have not approved it, there are not one case in the literature that is showing a very good results. So as you can see, we have used the Papyrus stent in carotid cavernous fistulas, in AV fistulas in different parts of the body, of pseudoaneurysm of the splenic artery, aneurysms of the right renal artery, aneurysms of the tibial artery, and so on. And there's a lot of things. As you can see, aneurysm of probably every part of the peripheral vessels you can think of. The first case, very interesting, a 33-year-old male who presented to our hospital with complaints of abdominal pain. There is a history of acute alcoholic pancreatitis, and he had undergone an endoscopic stent implantation in the pancreatic duct and pancreatic sphincterotomy, and multiple transgastric drainages because of all of the collections around the pancreatis. And we decided to do a CT, which revealed a big aneurysm, most probably iatrogenic, of the splenic artery in an extremely tortuous segment. So, of course, we decided to attend endovascular treatment of the aneurysm, and we decided to implant a Papyrus. As you can see, the approach is right brachial artery. We cannulated the celiac trunk and tried several different wires to go to cross the aneurysm without going into it. Basically, we did it with a whisper positioned in the distal segment of the splenic artery. Yes.
I want to show them.
Of course.
Кое служи като поинтер? Към екрана. You probably can observe the cutter is coming from above. Entering inside the. In fact, it's coming. The cutter is coming from the arm. It's coming from the arm, from the brachial artery. We have a publication of more than 1,500 brachial approaches. So there is a, let's say, the legend of the dangerous brachial artery. In fact, it was true in the past. In the past, the endovascular procedures were done with 7, 8, 9 French sheets. Nowadays, we are performing with 5 and 6 French 99.9% of all the procedures. And because of that, the brachial artery is extremely safe access, extremely safe. So in case we have a pathology on the visceral and renal level, in tall guys, radial artery, it's not possible because there is a distance from the radial artery and the visceral vessels. And in tall guys, there are no guiding cutters of 120 centimeters. The main part of the cutters are 100 centimeters. In order to shorten the distance to the tip of the catheter, we are shortening the access point. So in case, instead of going radial, we are going brachial. And on such a way, this is probably or internal mammary with a special curve, or it's possibly internal mammary. So only in such a situation, the extremely tortuous, in fact, celiac trunk can allow us to go deep by the wire, by the balloon, and by the stent. So from below, from the femoral, it wouldn't be possible at all, because it's a different trajectory from below to go and to go down. It's absolutely impossible to take all these tortuous segments from the femoral artery. And because of that, the upper brachial approach, the only one possible with deep intubation, Sorry about interrupting you.
No problem, thank you. As Professor Petrov said, then we implanted the Papyrus and did a post-dilatation with a non-compliant balloon. The post-implantation result is excellent, full isolation of the aneurysm, and no residual abdominal pain in the post-intervention period. We have a 4 years follow-up of the patient and no rehospitalization connected with this disease. And here you can see the Papyrus stent is shown there, and there is no aneurysm anymore. The next case is a coronary patient, 59-year-old male patient with ischemic heart disease, right coronary artery, and marginal occlusion of the circumflex artery with stented LAD with a very big osteoaneurysm. He has a typical risk profile with good ejection fraction, no hemodynamic significant valve lesions. Because of the anatomy of the aneurysm, because it is an osteoaneurysm of the LAD, very close to the circumflex artery, we did a pre-procedural CT scan in order to measure the exactly lesion length and anatomical marks, and decided, of course, implanting a covered Papyrus stent. Here you can see the CT scan showing the exact place of the aneurysm of the LAD. And here you can see the aneurysm. The one going to the left is the LAD, and the other artery is the circumflex. Here is the after implantation of the Papyrus. You can see that there is no aneurysm here, so it is isolated, but we have a very, very bad flow into the circumflex artery. So after that, we secured with a guide and did a kissing and stenting of the circumflex artery. Here on the second video, there is a little bit of blood coming to the aneurysm, but we thought that it's maybe a retrograde flow from the diagonal branch of the LAD. Here is a stent boost, and the final result, completely isolated aneurysm. So this is a case from a couple of days ago. The patient was okay, no clinical symptoms, and was discharged. So here I have shown you one literature case of a Papyrus coronary stent used for tortuous visceral artery pseudoaneurysm. Exactly case as the one we showed, our case before the coronary one. This was a 62-year-old patient with post-Whipple surgery for duodenal adenocarcinoma. The patient presented 4 months after the surgery with abdominal pain, and then from the CT scan we saw pseudoaneurysm of the hepatic artery, and the diagnostic angiography revealed 2 adjacent pseudoaneurysms, a large broad-based one, and next to it a smaller narrow-necked within 2 to 3 millimeters of one another. So we did stenting with 2 overlapping Papyrus stents, and which demonstrated a complete coverage of the both aneurysms, increased diameter of the hepatic artery, and markedly improved opacification, and of course blood flow in it. So that's it. Thank you.
Thank you so much once again. Excellent presentation, and yeah, we are probably a little lazy, but we had Dr. Antu from Skopje. He mentioned that he had used Papyrus in several patients with peripheral pathology. We can join the data and publish together, and we can make a case series for publication. Comments, questions? Proposals? Tatum, what do you think? Is it a good idea? I think it's, yeah, Papyrus. It's a matter of on-label, off-label. It's like I say many times, everything in the medicine that is on-label now, in the past, used to be off-label. So, yeah, this is the progression, absolutely. Donald, what do you comment?
I think it's beautiful. It's elegant, it's beautiful.
Okay. Excellent. Okay, we can probably thank Dr. Vasilev.
Thank you.
I think with this we are finishing with the program.
Yeah.
And thank you for being here with us. And tomorrow we'll have a really exciting program.